palpation, all that good stuff. All right, let's get busy. All right, so we had this the other day. Lots of big bony landmarks here. Notice the orientation of that SI joint, very planar. You know, there's some curvature and some irregularity, but for the most part, it is a sagittal plane type of orientation. What else do you notice here? Is this a male or a female pelvis? Can you tell?
A male.
Male.
Why?
Smaller.
Smaller, narrower. Yeah, I would agree. That's probably a male. Good. So again, made up of 3 bones. You'll hear this term innominate. Anybody heard that before? The pelvis in general is termed the innominate. A lot of old literature will have that. 1 fused sacrum and 1 fused coccyx. How many bones are fused in the sacrum? 4 to 5. And how many in the coccyx? 3 to 4. I don't understand the variability either, but if you look at the sacrum, you can kind of see how that's oriented. And the coccyx, maybe there's 3, 4, something along those lines. But anyway. Pelvis made up of 3 bones: ilium, ischium, and pubis. Again, we had a sacroiliac joint that we said is planar. Again, look at this extensive ligamentous structure here, okay? And I do not want you to worry about naming all these things, but just look at this, and then tell me that this is going to come out and come in. I just don't see it. I don't see it. But people will tell you that does happen. And it can. It just has to be much more violent than walking down the street. All right, so from the acetabulum, the one picture we had the other day that separated it into thirds is a little bit better than this one, I think. But just talk about it a little bit different. So this acetabulum, the socket of the hip, faces laterally. I think we can all see that, right? Faces anteriorly, so it's not in this plane, it's a little more in this plane, okay? More so in women, right? And it faces inferiorly. You can definitely see that too, okay? The legs coming down, and that's slightly more in males for that. But look at the orientation here of the angles. The labrum, just like in the shoulder, we've got labrum in the hip as well. That's become much more of a thing. You'll see the abbreviation now in charts, FAI. And that stands for femoral. I can't.
You can erase it.
Can I?
Yeah, they should have that.
Last chance, anybody? I'm so quiet today.
I was saying the same thing.
They're over it. Y'all got this August 25th thing? Everybody knows that by now. All right. F-A-I. Femoral. Acetabular. Impingement. this abbreviated frequently in the charts. So, what does that mean? So acetabulum, we know what that is. Impingement, remember we had that in the shoulder, right? What things could get impinged? In the shoulder, it was a rotator cuff, bursa, maybe even the labrum a little bit. That is what's happening here, more than not, is that this labrum gets pinched, okay? Now, it used to be, not even that long ago, 10 years ago, 15 years ago, they didn't fix labrum. They just waited until it got so bad that they would have to go in and just totally replace the joint, do a total hip. Now they can do this arthroscopic hip procedure where they can repair the labrum, okay?
Is it due to overuse too?
It's usually due to overuse, and it's usually due to, I don't want to say overuse. Sometimes it is overuse, but a lot of times it is some trauma that happens. And again, because we got such a stable joint, it doesn't come all the way out and do like the shoulder does, but it will sublux and then go back in, and when it does that, it'll pinch off a little bit of that labrum, and that becomes a problem because it's very painful. But it's hard to fix because again, you get such a stable joint here, and it's deep. I mean, think about how deep your hip joint is to everything. Your shoulder's right here, you know, easy access, portal sites, all that type of thing. To scope a hip is a big deal, right? You guys are gonna see more of this, certainly than I saw. I think I saw the first arthroscopic hip probably about 10 years ago. And there was a guy in Winston-Salem, they used to send me a lot of them, and it was a very detailed, he was one of the world's leaders in this surgery. Very detailed rehab protocol. We'll talk more about that this summer. But got to think about how this is oriented, okay? So in terms of the hip joint specifically, we do have articular cartilage that's covering the femoral head. We've got that labrum there. We've got a joint capsule. We've got lots of ligaments. We saw those the other day. Here they are again. Okay. And a super tight fit here. Okay. Doesn't dislocate. Obviously, it connects the lower extremity with the trunk. We've got a ball and socket. We've got 3 degrees of freedom. Our closed pack position. What does closed pack position mean again?
Where it best fits.
The best fit, the most congruent fit, okay, is extension, abduction, and internal rotation. That is when it's at its tightest, okay? Now, if you think about it, if you look at, for an open pack position, where would we want to mobilize it, where it's the least packed? Pretty much the opposite of this. Flexion, abduction, and external rotation. So I'm going to show you guys some hip mobilizations that I do, and they're all in that position for the most part. Okay. Our capsular pattern, and what is capsular pattern again?
That's what's gonna hurt the one hurt.
Not necessarily hurt, but when the hip gets stiff, what is it going to present as, most commonly? Okay? So if we just put you, say don't move your hip, this is what it's going to end up looking like. Internal rotation, flexion, and abduction. I don't see the abduction, but definitely the internal rotation and the flexion. You're going to see somebody with a stiff hip who's laid in bed for a long period of time, been immobilized. Maybe they've had some type of respiratory event and they've been put in the hospital and they just sit there. Well, they sit there and they get like this, okay, and their hip gets really stiff. And then they come out of bed and they're like this. And that's why you gotta start mobilizing that deep hip flexor we were talking about, okay? Stop me if something doesn't make sense, okay? Here's basically all the muscles that we studied, minus about 8 to 12 of them. lot to deal with. So here's our external rotators. Again, they all line up. Again, you know piriformis, you're gonna be fine. All the gemellis and the obturator, all that good stuff. Posterior, you got glutes, adductor magnus, IT tract, all the hamstrings. We went that ad nauseum. You're gonna be fine with that. So we talked a little bit about this the other day. This details it a little bit more, and I told you we'd come back to it. Inguinal ligament, okay, running inferior medially here. That's the top of it. ASIS, the pubic tubercle. Medial border is the adductor longus. And then the sartorius, that thin, long ribbon muscle that we had yesterday, is the lateral border. Okay, now within this triangle, we said there was a lot of neurovascular structures. This is a mnemonic I want you to remember. Naval, okay? So moving from lateral to medial is the femoral nerve, then the femoral artery, which we palpated and felt the pulse yesterday, or hope you did. Right next to that, arteries and veins run together, so it's gonna be the vein here, and the great saphenous vein as well. Then an empty space, that just kind of fills in the mnemonic, and then the lymph nodes we talked about. And we said there was, what, 8 to 12 lymph nodes in there. Them are raisin size types of things. They get swollen. You can palpate that a whole lot easier. But that's an important structure for reference here. Okay? Femoral triangle. We've already talked about the planes of motion. I think you guys are good there. Sagittal plane, flexion to about 120. Extension to 20 to 30. You guys are young, you're probably gonna have more than this. We'll check it today. Notice it says down here, we'll use 120 degrees of hip flexion. The AMA, American Medical Association, indicates hip has 100 degrees of flexion. We've got more than that. What's gonna get in the way of more hip flexion?
Muscle.
So you could have big quads, and that could get in the way?
Tight hamstrings.
Not usually. It would be more of the hip extensors, and I know hamstring is a hip extensor. It'd be more tightness in the glutes and so forth, but that's usually not the case. What else? It's more obvious. Maybe not on me.
5%.
Okay.
You got people who are huge here that can't get past that, okay? So you're gonna have some soft tissue and even adipose restriction for hip flexion.
So what would you, is there like an infinite?
It's gonna be pretty soft, to be honest with you. It'll be, I don't know, we'll do it on each other. It's gonna be variable. Hip extension will be a firm infield. AB and adduction. Abduction to about 45. Adduction to 20 to 30. And when we say adduction, that's crossing the midline, okay? So the way to do that, we'll show you how you measure that later. What's also important about this is that we want to stay in the frontal plane with these, okay? What we don't want to do is start internally and externally rotating as well, especially when you start doing manual muscle testing and so forth. If you are staying in this plane, stay in that plane, okay? We talked about how glute med's gonna do this. Well, that's great, okay? But as soon as someone's got glute med weakness, what are they gonna try to do? They're gonna try to externally rotate and substitute with all those piriformis, gemellis, obturators, everything else. So you gotta keep their toe pointed that way. When you're testing them, not so much the testing, but more about the exercise, okay? So if they've got a weak glute, don't let them do, can you all see me? Keep them doing this, not this. Does that make sense? Because they start, when they externally rotate, they're using the external rotators, even the hip flexors to help lift that leg, as opposed to the glute med. So keep them in line there. Don't let them cheat. They will try. All right, so we're talking about the retroversion and anteversion. We talked a little bit about this at the shoulder, but it's much more significant in the hip. So normal anteversion, okay, so this is the orientation of the acetabulum, femoral head, and neck, okay? Normal, 15 degrees from this frontal plane, okay? This is normal. So that's gonna result in your toe being pretty much straight ahead when you walk or when you stand. Everybody's seen people though that are pigeon-toed or walk with like a cowboy there, toes out, bow-legged, everything else, right? This helps to explain that. If we have excessive anteversion, if this angle is more, what's that gonna look like? Think about it. If this is the retroversion here, less, this is toe in. Can we see that? No? All right. So here's our hip joint. If we had more of this angle, it's bringing the toe this way. So if that's a normal, this is going to be toe in. So excessive anteversion is going to bring the toe in more, to more of an internally rotated presentation. This is more retroversion, a lesser angle of anteversion. This is relative retroversion. Less than 15 degrees, you'll see more toe out. I'm getting deer in the headlights.
Seems like it would be opposite.
Yeah.
Yeah.
You gotta look at the orientation here, okay?
Where is the, I guess I'm trying to see like, where is the femur moving in order to?
So what happens
turn
is
toe
the
in?
femur,
Like,
right,
is
so
this not
this-
in bed?
this is normal, okay?
Right.
So here comes the neck, and the femur's coming out this way, right? So this is gonna be a normal presentation. If we have this excessive anteversion, which increases this angle this way, that toe is gonna come that way, it's gonna be in more. So if you see, this angle doesn't change. This is the angle that changes. So the toe is gonna be more inward this way, as opposed to right here, what this is more, it's still anteversion, but only 5 degrees, so they call that relative retroversion. That's gonna be an externally rotated position, yes.
Is that for stability? Like from the knee joint, I guess? Is it from the knee joint down? It goes that way because the hip is going
This
this
is all
way?
happening here, orientation wise. And it's got to do with the position of the femoral head and neck in relation to the acetabulum.
This is just how, depends on how people are born, or is it something
Yes,
that
it can be
happens over
that.
time?
It's more about the bony formation than it is about muscular tightness and all that type of thing. There's some that can play a part of that, but this is more about a how you build type of thing. Okay? So if you see, if you see somebody with toe out, I want you to think that they've probably got some retroversion there. If you see someone that's toe in, you're gonna, or excuse me, toe in is gonna be more anteversion, okay?
So the normal for that is 15, so at the top.
Normal's 15, normal's 15. And this is something that's only measured through x-ray. It's not like we can measure this, okay? You can kind of, sometimes you can get an idea by palpating someone's greater trochanter and then having them internally and externally rotate to see where it feels like it's most, but that's very unscientific. This is something that would be done during it through X-ray. All right. I want to make sure we're okay though. I know it's a difficult thing to see because this is two-dimensional. We're talking about a 3D thing.
It just looks backwards.
If you have to think of it as backwards.
Doesn't make sense.
Could you, like demonstrate on the model how this works?
I can try.
Cause it does
Seem backwards? Okay.
Oh,
Fixed.
so Doc,
Yes.
it's just the head of the femur, like that area is turned.
Correct.
Okay.
Well, now it's got to do with a little bit of how. So if we go back and we talk that some people have. We said it faces laterally, anteriorly, and inferiorly, okay? And a little bit more in males versus females, all that kind of thing. That's all fine and good. What this is talking about is exceptions to that rule. And again, the motion that you're, not motion, the angle that you're measuring has got to do between the middle here, the middle of the femoral head, through this horizontal plane here. Okay, so again, normal's gonna be 15 degrees. I think the best way to show you guys this.
Right, but it's just the femoral head, right?
Yes.
It's not
Yes.
the whole, so just the top of the bone basically is turned a little bit, so that makes the leg.
The pelvis
Right.
isn't changed. It's got to do with the way the hip is,
Right.
okay? So if we've got normal here, if we've got more, can you see anything? If we've got more of an angle. How do I do this? Yeah, that's helpful. So here's our normal 15 degrees here, okay? And again, think about what the foot's doing. All right. Actually, you can see this one better because it doesn't have a muscle. Let's get his arm out of here. So here's our normal 15 degrees, normal anteversion, okay? And his toes pointing this way. All right, so if we have excessive anteversion, so this angle is going to increase, okay? It's going to result in a toe in. If the angle, see how the angle is increasing? This is normal here. Then I'm going to increase this angle and make it more this way, toe in. If I take it back and this angle gets decreased, you see how toe goes out. So again, this is what we're looking at here. If this gets flat, this has got to go out. If this increases from this is the 0 point, 15 degrees, what does it say, 35 degrees there? You're going to have a big time toe in. So it's all about this angle here. Is that a little easier to see?
Yeah, but the way the shoe is oriented in the thing makes it
Yeah, the
seem like
pictures of-
it's going this way.
That's a
But
good-
what this is doing, yeah, I see what you're saying here. But now if you're looking down at this is going to be toe in. Okay? Does that make sense now?
Yeah.
Okay. It's a tough thing to see, again, because it's 2D. We're talking about a three-dimensional thing. But this is our angle. And this is 15 degrees when it's normal. When it's more, it's going to be toe in. When it's less, it's going to be toe out.
Would you also think of it as when your greater toe cancer goes forward, is your toe in as
And
well?
I would be fine with thinking that.
Nice.
So you're saying like when the head points posterior, toes in, head points anterior, toes out?
Head, be careful now. Head
Like
Say it again.
points posterior towards.
Points posterior, it's gonna be more toe in.
Mm.
Okay. Yeah, I can deal with that. But again, it's a little more precise in saying 15 degrees versus 30 degrees, that type of thing. Okay. Again, this is just a characteristic thing. It's not a lot we can do as clinicians about this. Because this is a bony thing. Right? But that presentation of the toe in is something you might see, or toe out.
So like, how do you say we may do nobody like clinically? How would that relate back to like, or like affect your
All right, well,
exercising theory?
let's talk about that then.
Would it
All right, so
depend
if
on
I've got
what-
somebody who walks like a duck,
Right.
where are they gonna be tight? External rotation is gonna be tight, right?
Right.
Your external rotators are shortened as a result of that.
So,
So what comes first, chicken or the egg?
Yeah.
This comes first,
Okay.
okay? You're born with this, then your muscles get tight because you walk constantly in that position.
Right.
Is that what you were asking?
Kind of.
Okay.
Yeah. Kind of.
Okay. Difficult concept, I get it. We're okay? We'll revisit? Okay. Might be something you just gotta sit up here and play with it a little bit too, alright? Coxavalga. We said valves were wider at the bottom, right? That's all this is. You're gonna see this orientation is wider down here. Doesn't come in as abruptly. So coxavalga. Hip deformity, angle between the head and neck is increased, greater than 135. Normal is, this is a 135-degree angle right here. Come on, there we go. 135 right there. This one's probably more like 150. This one's probably closer to 100. Coxavera. Okay. Which one of these is gonna be tend to be more bow-legged?
Coxavera.
I'd say Valga.
Valga is gonna be more bow-legged, okay? Because the orientation's out this way more. Normal, Vera is gonna be more knock-kneed, okay? But again, that's all dependent on the knee too. That's why it's hard to talk about one without the other. So here's our normal angle. And if you've got less than that, here comes this knock-knee positioning here. And that effectively decreases the leg length. Yes, sir.
So if you have a hip deformity, would that cause you to have a knee deformity?
Certainly can. Yep. The kinetic chain we talk about, one affects the next, which can affect the foot and ankle, all of that, correct.
Okay, so this is like ball formation. Like, what do you do with athletes then? Like, because like
A lot of times you do nothing,
they
because their
just-
bodies accommodate
So
to
like
it.
when they squat, like I have a girl once and she squats on her knees up, it's like it's kind of hard to fix.
Oh, we're gonna have fun with this in the summer. When someone squats and their knees go in like that,
Right.
where is that normally a sign of weakness?
LCL.
It's gonna end up impacting, not LCL, more MCL, in the medial knee. But it will impact, if you watch, especially if you watch, so, gosh, you give me all of them tangent. Females have what higher incidence of ACL injuries? Almost 7 to 1, okay?
Because of the Q angle. So.
Because of Q angle is part of it, and we'll talk a little bit about that later. But because of Q angle and because of quad weakness and glute weakness, they land and go into valgus. And that puts that stress, that rotation or force is what tears ACLs. So what do you try to do? Train quad and train glute to not have them come into that position. But if they're already set up and they have more of this to start with,
Yeah.
tremendous disadvantage to them. Because this is bony. We can't do
Right.
much about this. Okay? So this is our knock-knee person. This is our bow-legged person. And they have an increased leg length. And again, this is regardless of what's happening at the knee. There may be some other factors there that are going on there. We're spending a lot of time on this. I don't want you to get too hung up on it. It is what it is, but it's not something we can change a great deal. So, there are other factors that can determine this as well. If you're older and you have a fracture, this can change this angle of inclination as well. Slip capital femoral epiphysis. When they take your kid into the pediatrician, do you remember them doing a test on their hips where they do like this? That's what they're testing for here. If they go like this and they go into external rotation, and they're kind of loading the hips when they do that. Y'all know what I'm talking about?
Yeah.
They take the kid's hips and they do like this, they're on their back and sprung. If one of them kind of clunks or anything, this is what they're looking for. And this can happen pretty frequently. So this orientation then will change that angle and determine what the whole rest of their leg is gonna look like. So if they catch this early, you know, they can help to prevent that congenital deformation or deformity.
So you can move it like that?
You can be. Sometimes it's traumatic because these are on growth plates and so forth, but more times than not, it's just something that has happened. Whether it's, you know, I don't really understand it because this is mostly seen in pediatrics, which I didn't deal a whole lot with. But you guys talked about that yet? Slip capital femoral epiphysis and all that, yeah? Ortho stuff? Peds, yeah. Rightly so. All right, pelvic tilting. Everybody stand up for a second. Stand upright with your neutral pelvis, okay? You're just standing there normally. I want you to tip your pelvis. Think of the pelvis as like a big cereal bowl. You're gonna tip the milk forward. All right? What contracted and what got stretched?
Quads,
When you
hips.
went anterior, what contracted? Erector spinae, big time, okay? What got stretched? Rectus, obliques, any of the abdominals. What else though? Hamstrings. Ischial tuberosity is coming north. So it's gonna stretch here. So what does that mean hip flexors do? They shorten. Okay? Come with me again. Anterior tilt. Stretches hamstrings, tightens hip flexors. Tightens extensors. Does that make sense? Okay. Now we're gonna go the opposite way. We're gonna tip the cereal bowl backward. Okay? Flatten the back, so we're stretching the erector spinae, tightening abdominals, tightening hamstrings, and stretching hip flexors. Hugely important that we see this, okay? Because this is something you can influence, big time, big time. And think about all the things that this now uses in. Think about all the units of the body that this is affecting. People with back pain, huge. People with tightness in hamstrings and hip flexors, huge. Abdominal, people with poor strength in their abdominals. You can impact this in so many different ways, okay? But I need you to be able to think through that clearly. Yes.
This is kind of random, but like I feel like when I lay on my back, like my back actually never hits.
Never flattens out.
Right. So like, does that mean I have is that because of my pelvis tilt?
It probably is just due to the way you're built. You might have more lordosis here. But it could be that your abdominals don't fire like they should. I think that's probably unlikely. I think it's probably more of the structural increased lordotic posture. But can we teach you how to do that and do it better? I think we can. I think we can. I haven't seen I've seen it in the clinic. If you work with people on this, they get better at it. So therefore, if they get better with it, they have better pelvic control. They have better control when you tell them to get into a neutral spine position. So they can lift better. They can sit better. All these things are important. That's why you can't just, we studied spine, trunk, and then we come and study hip. And we really just started talking about this. It all's got to come together, okay? And this even talks about the ligaments too, which I'm not making a huge deal about there. But everybody see this? All right. So if we're looking at hip and pelvis, inspection and observation, just like we have on every other joint. Surgical incisions and scars. You're gonna see a lot of total hips out there. Old people like me are gonna have more and more of these things. We haven't talked much about the procedures of total hips and so forth. We had an interesting question this morning. Tell them what you were asking us this morning.
Okay, so like, if a hip replacement replaces like the joint and the like structure of it, and muscles like attached to bone, so when they do like replacements, where do they put the muscles back? If that makes sense.
It's a great
Does that make
question.
sense? Okay, yeah.
It's a great question. So the easy answer to that is they really don't do that much to it, because all they're changing is the joint. Now, they gotta cut through muscle to get to this, but all they're lopping off with the bone saw is right here. And they're putting in a new liner of the hip here, and they grind that out. But they pop this out. Don't y'all wanna watch? They pop this out, they bone saw this. This goes spinning off like a billiard ball. They take a metal component and they jam it in here with a hammer and a chisel. They put a new liner in here, and then they pop it back in place and sew them up. It's inherently stable. Gosh, she's got some bad posture now too. Bad shape. But there's not that much that they do to the muscles. Now the hip is a gory mess because they can't tourniquet and cut the blood supply off. So they're constantly suctioning and all that kind of stuff. Do y'all wanna watch it, or do you wanna just do that on your own? All right. No, the knee is, there's no blood. Oh yeah, it's more hammer and chisel, yeah.
And then like this dingy and all kind of stuff. It is very great.
My dad had to watch some of mine, rod in, drill a hole in the finger, and the rod.
I mean, it sounds like you would have something else to do, but what else could you do? Or you know, what else to do?
What, animation, I want the whole thing.
No, and it is really interesting, like the president, Shackett, if you talk to him, he tore his bicep, and they had to reattach it and use Kevlar, and the muscle fiber, and the tendon sort of regrew, the scar tissue grew over the Kevlar.
Graphic content warning.
Sign in.
Sign in to confirm your age.
Oh,
I understand.
Frank Ebert, MD, Chief of the Total Joint Service at Memorial Hospital, moderating a video on total hip arthroplasty. This total hip approach is an anterior lateral approach and is the workhorse for my total hip replacements. In the preparation for the total hip arthroplasty, it is important that all instrumentation is available and that adequate preoperative templating is completed. The prepping and draping is done in a fashion so that a Harris drape is used and this drape provides appropriate exposure for the hip. A 18 gauge spinal needle is placed to identify the tip of the trochanter. A curvilinear line is drawn.
Now, prior to all of this, they have taken x-rays and measured everything. Okay, so they've got, the size of every component that they're getting ready to do, and they'll have trays. You can't see them. That's the instruments that they're gonna use, but they'll have trays of prosthesis, because they've measured it, but you don't know exactly till you get in there and you fit it. So, again, there's a lot of prep work that goes in before this.
Once the draping is completed, the incision is made, which is located from the spot 2 inches distal to the trochanter, curved anteriorly towards the iliac wing. Usually the proximal length of the incision above the level of the trochanter is 3 to 4 inches. Total length of the incision is anywhere from 5 to 6 inches. Dissection is then carried out to expose the tensor. Hemostasis is obtained in the fat layer. In this video, anterior is to the right and posterior is to the left.
Are you oriented
Use
okay?
the cautery to split the tensor. In this video, anterior is to the right and posterior is
Anterior to the right, so this is anterior, this is posterior.
to the left. Use the cautery to split the tensor, and once this is done, it will allow for
That is a
visualization
wonderful
of the abductor musculature.
It's like bacon.
And they're just cutting through like everything.
Yep.
I would feel that right
Obtain
there.
hemostasis throughout the whole process.
It's happened many times.
And they were like, come get her.
Happens more times than you would think.
The meskimen retractors are used to provide linear retraction. This technique allows for the creation of musculoosseous flap, which is created by splitting the abductor at the middle and anterior thirds, and then placing a Homan retractor to define the medius tendon and minimus tendon. Incision through the minimus, which you see in this view, is carried down through the capsule, which then allows for a visualization of the hip joint.
So basically going through two muscles right now.
The joint is then identified, carried to the tip of the trochanter, and then once at the tip of the trochanter, a Homan retractor is placed around the anterior neck. With this, a osteotome is used to take off an anterior wafer of bone off the anterior portion of the trochanter.
Hammer and chisel.
This creates a musculoosseous flap, which can be retracted like the leaf of a book and allows for clear visualization of the hip joint. With this, a leg length measurement was taken by utilizing a Steinman pin drilled at the superior portion of the incision. The Steinman pin is then bent. It allows for identification of a leg length reference point on the trochanteric bed. Sometimes a sharp Homan is benefited by placing it posteriorly, allows for further dissection and removal of the soft tissues. Dislocation of the hip is accomplished by adducting the leg and externally rotating the leg. A Homan retractor and the double prong retractor allow for visualization of the neck.
I hate that y'all don't get to go in the OR and see.
Patient then has a neck cut, usually made in a fashion that the saw and neck are perpendicular to one another. The cut begins at the saddle of the femoral neck and extends perpendicularly. Once we begin the femoral preparation, final neck cut will be made. The purpose behind the two neck cuts is that a more right angle neck cut will allow for better retractor maintenance when the fang retractor is placed about the femoral neck.
So they just like pop it up, in a sense, to like pull the head out.
Yeah, so he's dislocated it, so it's sitting there, now he's cut it. And now he's
Pops
taking
it right out. Yeah. Looks like a plaster.
So the leg just.
It extends perpendicularly.
Never mind.
Once we begin the femoral preparation,
Now he's cutting the neck,
final
And
neck
that's
cut
what they
will
about
be
to go
made.
in and.
The purpose behind the two neck cuts is
pop it
that
right out.
a more right angle neck cut will allow for better retractor maintenance
When I was in there,
when
this
the
thing
fang
went
retractor is
flying,
placed about the femoral
and
neck,
it's rolling around,
anchoring it off
rolling
the
around.
posterior of the acetabulum.
Will they let you take it home?
And the retractor system's in the set. An anterior retractor is placed along the face of the acetabulum at
Oh, what's that
approximately
cool
4
rock? That's the
o'clock.
head of my femur.
A fang Homan retractor
Up
is
on the
placed
mantle.
at 8 o'clock. And with this approach, the key is the incision of the inferior capsule. Once the inferior capsule is incised, this allows for freely transferring the femur laterally, and then the excision of the labrum can be performed either with a sharp knife or cautery.
And this is a
The
reamer.
reamer then is used to ream the acetabulum. Typically, the reaming is done in line with the rims of the acetabulum.
You gotta smooth it out.
Gotta make it smooth.
In this fashion, the reaming then will allow for the demonstration of punctate bleeding bone with excellent fit of the reamer into the acetabulum. For the trilogy
Even
system,
carpentry.
a 1 millimeter underream is used, and for the trabecular metal system, it is reamed line to line. Taking out the reamer and placing it in the acetabulum allows for assurance that you have adequate reaming, which is going to give you a good press fit within the acetabular rim. All remaining soft tissue should be removed from the rim of the acetabulum so that
Cut away all the labor.
there is no interference of that soft tissue when the cup is placed in the acetabulum. The alignment jig is put in place. Typically, I place the screws at the superior portion of the acetabulum. Once this is seated, for version, align the cup based upon the rim of the acetabulum. The native acetabulum will usually place it in an appropriate version.
Is that what you just said?
In cases of large osteophytes, try to make an
Is that what we were talking about, like the version? You
Yeah.
said? Okay.
Yeah, he's trying to make it normal at this point.
estimate of the position so that it's an appropriate anteversion.
There you go.
Abduction is based off of the vertical portion of the alignment system and should be slightly past perpendicular to the floor. Once the cup is seated and felt to be satisfactory, additional screw fixation is done with two 6.5 cancella screws placed in a 1 o'clock and 10 o'clock position. Polyethylene liner is seated in place. In this particular instance, the cup was 54 millimeters and a 36 millimeter polyethylene liner was seated.
That's pretty slick.
Yeah. How long do they use?
For cup sizes less than,
From start to finish?
This whole procedure takes about 45 minutes.
That's pretty fantastic.
45 minutes to an hour, depending.
52 millimeters typically will use.
Is who does most of the hips at Columbus? I know a lot of them do, but who does the most? Landry does a bunch. He'll do like 8 in a day, 10 in a day. Yeah.
How soon is the patient up walking
That day.
that day?
This is now a quote outpatient procedure, correct?
They do it things like that too, right?
What about, I know it's a newer thing, but the bikini, I feel like one of our doctors does it, so how is it a little bit different?
I don't know enough about it to tell you. Do you know about the bikini thing that they've been talking about? I don't know about it. I've heard of it, but I don't know
Like
what it is.
two of our doctors have done it, and they go like in the bikini line of it.
Yeah,
But like,
it's an anterior
mm-hmm.
technique, but I don't know.
Going on the bikini line?
Mm-hmm.
No, I haven't seen it. I've just seen the traditional.
We have like 2 or 3 patients, and they were literally like done with therapy in like 5 weeks,
Yeah.
just because how fast it is now. But I was just wondering how
Going through less
different it
muscle.
was. Mhm.
Well, I mean, I think an anterior approach regardless, they are faster anyways.
We'll talk about all that this summer. Did you have a question, Mom?
No.
Want to volunteer?
Do I want to volunteer? No.
A 32, and for less than 48, I would use a 28 millimeter liner.
So they still have no.
With the leg in the anterior leg bag, exposure of the proximal
Head.
femur is
You gotta get one of those in there.
achieved, a final neck cut is performed. It's important to place the double prong retractor and sharp Homan retractors in a position so that it will allow adequate exposure to the femur and will allow for appropriate reaming as well as broaching.
So he's going down to try to put the femoral component.
The box osteotome is used to create a slot. Remember to go as lateral as necessary. And then in the connective or ML taper system, broaching is the primary source. This compresses the cancellous bone and achieves the appropriate fixation. The seating of the stem is done. And then once the stem is seated, various neck lengths are chosen from preoperative templates, and then an appropriate femoral head is chosen, with the hip being relocated to check not only the shuft
Forget it's a human.
of the
You
hip,
see the leg.
but also the motion and stability of the hip in both flexion, adduction, and internal rotation, as well as in extension and external rotation. Assess visually whether or not any impinging osteophytes are present. Then check your leg length measurement to ensure that it is an appropriate length based upon the pin that was placed pre-dislocation. This gives a sense of the length at which the limb has been lengthened, and then you can measure the offset. With this ability, you can base this off the leg length difference that existed preoperatively, and in most cases you're able to make adjustments with the various neck lengths to provide for offset as well as leg length. Once the appropriate leg length is chosen, the neck is impacted along with the femoral head. In this system, the +0 femoral head is always used. Never use a +3, +5, +8 femoral head due to the concerns about fracture of the neck. Closure is done in a fashion such that the minimus tendon and capsula are closed in a deep fashion with number 5 Ticron. The bony wafer is reattached again with number 5 Ticron with 3 to 4 drill holes drilled through the trochanter and the bony wafer. And then once this is achieved, the drain is placed at the interval between the medius and minimus. With this in place, the closure is done for the deep tissues. The number 5 Ticron suture is excellent for closing of these deep tissues due to the fact that it cuts through bone well and makes it easier for placement and subsequent closure. In most cases, there is bone-to-bone healing of this wafer. In some instances, I have had a small amount of heterotopic bone formation, but for the most part, the dissection allows for a more secure closure of the muscular flap than if the abductor musculature is peeled off of the trochanteric bed with cautery. Once the wafer is tightly fixed, the minimus sutures are tightened and closed. Inject the cocktail of medicine into the soft tissues. Don't place a tremendous amount posteriorly, and then place the drain so that it comes out anteriorly and laterally. Remember to bend the drain when you place the drain so that you don't push the trocar of the drain into the femoral triangle.
The drain's usually in place for like a week or 2, right?
I don't think it's even that long. It's a good question though.
The fascia is closed with number 1 Vicryl, and the tensor is closed with number 1 Vicryl, with the remaining subcutaneous tissue closed with 2 and 3 Vicryl. I prefer to do a subcuticular stitch in light of the fact that most patients like the cosmeses of the subcuticular stitch and feel that the appearance of the scar is extremely important for their sense of outcome. This concludes the discussion of the total hip replacement done through the anterior lateral approach.
That's a neat job. More times than not, they're just using staples now. All right, take a break.
Where's the poop?
Good question.